Hello everyone, my name is Dr. Hulum Habat, and today we are going to be discussing about hemolytic disease of the newborn, HDN for short. Welcome to the channel, and let's dive in our discussion today. So HDN is a condition where we have an incompatibility between the blood types of the fetus and the mother. So mainly positive for the fetus and then versus negative for the mother, and it's also called erythroblastosis fetalis due to the erythroblast, the red blood cells, being involved in the fetus. So it's an alloimmune condition that develops in this fetus when the maternal antibodies pass through the placenta. We're going to look through in the details of the pathophysiology. So rhesus negative blood groups are quite rare, but we have about 1% to 36% of the people are rhesus negative, and it varies in different populations. And you have rhesus alloimmunization in this condition occurring in 1 out of 100 women prior to anti-D. We shall look into that shortly. And then the newborns which are born to these mothers who are rhesus negative, they're about 3 to 8 in 1,000 patients worldwide, and 35% leads neonatal deaths from this rhesus disease occurs in sub-Saharan Africa. So the common cause of this is rhesus, anti-rhesus antibody, which will be the focus of our discussion today. We can also have the ABO incompatibility, which is the second most commonest, and others anti-Duffy, anti-Kell, anti-Kid, MNS antibodies, which are quite rare. So in the pathophysiology, this is where the genesis, this is where things all stem up from. So it starts when the mother is rhesus negative, that is blood group negative, or for example O minus, B minus, and all that. So and the father is rhesus positive, and during reproduction the fetus can easily take any of the blood groups, either the rhesus positive or the rhesus negative. So when the fetus takes it, there is completely no problem because the mother is negative and also the fetus will be negative. So the problem comes in when the child, like father like son, takes the blood group of the father, and that is the rhesus positive, and yet it has to be inside the mother, which is rhesus negative. So that's where the problem comes from. So it becomes like a very, very big foreign body inside there. So, and the placenta does really quite a good job to prevent the maternal blood from mixing with the fetal blood. And this mainly makes the first pregnancy safe because there's literally no mixing. But in some scenarios, like someone having a ruptured ectopic pregnancy, abortions, placental abruptions, which can lead to mixing of the blood of the mother and then the fetus, so it can really cause some problems. And most times the subsequent pregnancies are the ones which are not safe because during delivery or parturition, we cannot prevent the blood for the mother from mixing with the one for the fetus or for the baby. So this mixing causes what we call sensitization. We have the maternal immune system will react by producing IgM and IgG antibodies, and these antibodies, they are produced against the rhesus positive fetal red blood cells which were just exposed to the maternal circulation. So, and this IgG takes quite a long time. However, in the first pregnancy is safe because its production takes quite a long time, so the first baby is always safe. But in the subsequent pregnancies, so maternal sensitization occurs when there's a repeat exposure, that is the second pregnancy, with still the fetus being rhesus positive and the mother being rhesus negative. So this anti-D antibodies, mainly the IgG, crosses the placenta into the fetal circulation and attach to the red blood cells, and they cause hemolysis by the lysosomes produced by the macrophages and then the natural killer cells. And this is just the illustration of the pathophysiology. So some of the outcomes, we have 50% having anemia, which is a presentation, and high bilirubin. 25% will require treatment, 25% will develop hydrops fetalis, we shall see shortly on the next slide. And those with hydrops fetalis, their mortality rates increases by 30%. So some of the clinical features, since there is hemolysis, there is destruction of the red blood cells, there is literally going to be low HB, anemia, and due to that metabolism of the hemoglobin, bilirubin is one of the products which comes out, and this bilirubin is deposited on the skin and in the sclera, so someone gets jaundice. That is, you can see yellowing of the skin and the sclera, as you can see in the illustration at this side. So hepatosplenomegaly, that is comes into play. This due to extramedullary hematopoiesis, comes in to compensate for the damage which is taking place. Then hydrops fetalis, this is due to accumulation of the fluids in one, two or more fetal compartments, as you can see in this illustration. So this comes as a result of hemoglobin deficits going below 7 grams per deciliter. So it will reduce the oncotic pressure, and we have fluids entering the interstitial spaces, ascites in the abdomen, pericardial effusions in the pericardial cavity, pleural effusions in the pleural cavity, generalized edema, and polyhydramnios. So some of the complications of this disease is that this bilirubin, which unconjugated and lipid soluble, so they have the ability to cross the underdeveloped or the immature blood-brain barrier of the neonate and can cause brain injury, neurological damage. So if this child survives, they are going to have some mental retardation in the future. Then respiratory distress due to low HB and reduced oxygen carrying capacity in these young ones. So how do you diagnose this condition? So history is very important, mother being rhesus negative and father being rhesus positive. And then when the child is born, there is rapidly progressive severe hyperbilirubinemia. So it differs from the other causes of jaundice. So this is rapidly progressing and is prolonged. So in the physical examination, jaundice, pallor, and edema, those are cardinal features which you cannot miss in this child. And in the investigations, you can do a complete blood count where you will have a low HB and nucleated red blood cells. You can also get low hematocrit. MCV could be normal or raised due to the reticulocyte count, due to the compensation. So the turnover of the production of the red blood cells will increase, so they end up releasing the red blood cells with nucleases into the blood. Those are immature red blood cells. Neutropenia, thrombocytopenia, these are common presentations on the CBC. And liver function tests, since the liver is one of the organs affected, you'll have low albumin, unconjugated bilirubin. So hemolysis in the blood film due to this destruction of the red blood cell by the IgG, very common. And then others, you can do maternal antibody screening, where you will find positive maternal antibodies. Positive direct Coombs test in the neonate. It's one of the confirmatory tests which you will have in these scenarios. So management of this condition, HDN, you can manage it at the before birth and then after birth. So before birth, you can do serial monitoring and then ultrasound scan, mainly the MCA, Doppler velocimetries. This is the middle cerebral artery. So, and you can also do intravascular transfusion, which is very, very important when the fetus is still inside the uterus. And then postnatal management, you have a few IV immunoglobulins which are designed to help in that. We shall see shortly. Phototherapy, exchange transfusion, and then supportive management by draining these ascites and perfusions once there is fluid build up, and then hemoglobin monitoring for 6 weeks. That is mainly on follow-up because there are occurrences of late anemia in these neonates. So starting with anti-D immunoglobulins. So these immunoglobulins are mainly given routinely at 28 to 30 weeks of gestation during pregnancy, or it can be given within 72 hours after delivery of the newborn. So it's like the antidote for these cases because it significantly decreases the risk of HDN in the next baby. How does this anti-D immunoglobulins, what is the mechanism of action? So they bind to the rhesus positive red blood cells, that is from the baby, the one which has crossed, has mixed with the maternal circulation, and they prevent the mother's immune system from recognizing these foreign bodies, these antigens which have crossed. So they neutralize, in other words. So they prevent the mother's immune system from reacting and destroying and producing the antibodies which will destroy the red blood cells in the next pregnancies. So, and this is very, very important, and it's a very, very good drug in this condition. So they also prevent antibody formation by the mother against the rhesus D positive red blood cells. That is due to its action of neutralization, or with preventing the immune system of the mother from recognizing these foreign antigens. Phototherapy, we have the blue light from the phototherapy, which provides energy that breaks this excess bilirubin and converts them to water soluble, and they are easily excreted in bile and urine, process called photoisomerization, used mainly to treat neonatal jaundice and prevent canicterus in these neonates. So we have complication bronze baby syndrome as a result of the light, the effect on the skin. And then exchange transfusion, we have mainly removing circulating bilirubin to reduce and prevent canicterus. So you basically remove the red blood cells which are already coated by the antibody, and then you transfuse fresh blood from the donor to replace that blood which you're removing. So it reduces the level of bilirubin and also prevents the complication canicterus. So when do you decide to do exchange transfusion? When the strengths of serum bilirubin are not responding well to the treatment. There's signs of bilirubin encephalopathy, that's the brain damage resulting from the bilirubin buildup, previous treatments, and underlying conditions. So basically in this, you're removing blood and you're replacing it. So some of it's labor intensive and has got lots of complications, as you can see. So be watchful of some of these complications as you do the exchange. Transfusion. So in summary, HDN is an alloimmune condition, usually due to anti-rhesus D antibodies, where the newborns can present with hydros fetalis, jaundice, and anemia, treated with phototherapy, IV immunoglobulins, and exchange transfusion. So we have come to the end of this lecture. Thank you very much for listening. Please like the video, share with your friends, and don't forget to subscribe if you're not yet subscribed, so that you don't miss the upcoming lectures on other topics. Thank you. Until next time, see you.